welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Well, hello and welcome to Brain Chat, friends. It's Dr. Mitzi, your board certified neurologist and MS doc, and I bid you greetings from hot Atlanta, which is actually hot. So we've been in the midst of a heat wave and it's over 100 degrees down here. I think today was 90, so that's a little bit better. But very excited to be here with you all tonight talking about, an amazing topic that we definitely need to raise more awareness about. Before we get into that, you guys know how we do on Brain Chat. Put in the chat where you are viewing from. I love to hear where everybody's viewing from. As I said, I'm in Atlanta. Show me in the chat where you're logging in from. So very excited. Today is Juneteenth. So I got my Juneteenth t-shirt on. And it is also Pride Month. So we've got a lot of exciting stuff to talk about. And I have an amazing guest here with me tonight. Dr. William Conti is an MS specialist at the Comprehensive MS Center at Methodist Hospitals in Maryville, Indiana. He's an adjunct assistant professor of neurology at Indiana University. He graduated from med school at Loyola University in Chicago. Chicago is my old stomping ground. I was born in the Chi. And went on to complete adult neurology residency at Loyola University Medical Center. He also completed fellowship in MS and neuroimmunology at the University of Chicago through a National MS Society Award. And while at the University of Chicago, earned a master's degree in public health sciences. He's been a principal and co-investigator on multiple clinical trials and investigator-initiated trials. He lectures on various topics, and he leads the Comprehensive MS Center at Methodist Hospitals in Maryville, Indiana. Welcome to Brain Chat.
Hello.
How are you doing?
I'm great, and happy Juneteenth.
Thank you.
So yeah, it's really
Awesome.
hot here, by the way, too, in Chicago. We're like dying. My poor husband's been out landscaping, and he's made this huge project, and it's just I come home and it's like, have you eaten? Have you drinking? Like, it's so hot right now.
Please don't have a heat stroke. Yeah, it's super hot. Yeah, I definitely understand. This weather has been bananas. So I'm very grateful for air conditioning and I try to stay in it as much as possible. And of course, as we were talking a little bit before the show, our patients are also calling and saying, hey, I'm having more trouble. This heat can really make MS symptoms kick up a little bit. So I've been getting a lot of calls. Yeah, about spasticity and nerve pain and other things like that. So make sure you guys try to stay cool and we can chat a little bit about that later. I've got a couple folks logging in from Denver, Colorado, and I've got somebody from New York, one of my favorite places to visit. All right, you guys keep putting in the chat where you're logging in from. And let's get into this topic. So it is Pride Month and I'm very excited to talk about MS and the LGBTQ plus community. This is a topic we have not talked about on Brain Chat, but I think one that's extremely important because as we raise awareness about underserved populations, certainly this is definitely an underserved population. So tell us a little bit about how you got into this work, how you got into MS, and then we can talk a little bit more specifically about, some of the concerns that we need to address.
Sure. So, how I got into MS. Well, I guess I'll start with back in the day, in college, 18-year-old, Billy Conti. So I wanted to do a lot of research. I was really interested in research. And the one lab I could get into without taking my prerequisites was a neuroanatomy lab through the vet school.
Wow.
And so I really wasn't interested in neuro at the time, but at that time, I fell in love with it very quickly, obviously. And so, then went to med school, and naturally, I was actually thinking about doing neurosurgery for the longest time. And I rotated up with them in third year med school, and I was like, oh, this is awful. Like the hours and just the competition that they were. I mean, they just kept competing with each other. I was like, guys, like chill
Yeah.
out. So I mean, neurology
Yeah.
was a natural next step for me. And
Yeah.
in my residency, I actually was lucky to have a lot of MS patients in my clinic, the residency clinic, and I just sort of fell in love with it at the time. I mean, this was in 2013 to 2017 was my residency, and it was
Mhm.
just when a lot of the newer drugs were coming out. So it was just like there's a
Yeah.
new drug here, a new drug there, and it was like, wow, we're making a huge difference in these patients, and it was just really cool. So um, decided to do MS. So I did a fellowship and
Yeah.
started an MS center basically, and here I am.
Awesome. Awesome, awesome. I thought about neurosurgery too, and God bless our neurosurgery colleagues, because I've
Yeah.
had to have neurosurgery once, and I need somebody good. But I thought about it for about 2 weeks, and then I changed my mind. I was like, "Yeah, I'm not quite that committed." So, hats off to
Yeah.
those of you who stick it out and help us, because I send lots of people to the neurosurgeon. But whenever someone comes and says, "Oh,
Mhm.
you're a neurologist, you do surgery," I'm like, "No, absolutely
No,
not. I am not the
no.
person you want doing surgery on you." Yeah. So very, very cool. Things have changed in the way that we treat MS. So our treatments have changed so much over the past 15 years. I've been in practice a little bit longer, but not very much longer. I finished back in two, 2008. And so when I finished, we didn't even have an oral medication. So things have come a very, very long way in a short period of time. But something else that's really come to the forefront is the need to better understand MS in certain populations, right? So, I primarily focus on MS in the Black population because, that's the community that I primarily serve. But there's certainly other populations that we're beginning to look at and say, okay, how can we best serve and provide really culturally, and how can we provide competent care, right, and really provide the needs of people and not put people in a one size fits all box. So kind of starting with that, thinking, what do you think, I guess, are why don't we start with this? What do you think are kind of the top issues that need to be addressed in the LGBTQ plus community in terms of MS?
So obviously, there's examples, very rare examples, thankfully, of like discrimination that happens to
Hmm.
LGBT MS patients. Obviously, that needs to change. But I think
Hmm.
more insinuously, like I think one thing I've sort of discovered in my research on this topic is that there's a lot of actually health disparities that LGBTQ plus people face, just
Mm.
as being queer, growing up queer, and being in the queer community. It's a minority group, and so the
Yeah.
health disparities I think then contribute to poorer outcomes with MS. Obviously, this isn't proven,
Hmm.
but because no one's researching this topic, and I think that's an issue in and of itself. There's I mean, there is data to show that, for example, like, just an MS patient who has other comorbidities, such as like hypertension, diabetes, like those things have worse outcomes, right? Because
Hmm.
it's a compounding factor. So I think the queer community, we're sort of at a disadvantage because of these health disparities that it could interact with the MS care. And I think more intersections with that could lead to worse outcomes.
Absolutely. And when we talk about health disparities, there are often a lot of issues with access to care, issues with, certain symptoms being believed. That certainly is a big issue, for instance, in the Black community, where people will go to the doctor and they'll report symptoms, and
Mhm.
people will look at them a certain way and really not believe the symptoms are having, or they may be thought of as psychiatric issues, or people were told that they're stressed or depressed, and it's kind of their presenting symptom of MS. Do we see that in the LGBTQ plus community as well?
So I think so it's hard for me to say because I'm biased. I'll have to be biased because I am, I'm gay, and I think I treat
Mhm.
my queer patients just like I would any other
Mhm.
patient, and so I'm aware of these things. But there is good research on the fact that patients who are queer report poor experiences with the healthcare system, right? There's sort of a mistrust. I
Mm-hmm.
mean, so for example, like I mean, it was the 1970s, I think, it was 73 when the psychiatric diagnostic manual actually changed the definition of homosexuality. They actually said it was a mental disorder. So like I think there's
Mm-hmm.
um, a lot of cloud from that still
Mm-hmm.
in the community. I mean, I think there's a lot of memories of the AIDS epidemic,
Mm-hmm.
sort of people being afraid of especially gay men at that time, and so I think there's a lot of baggage. As far as like MS goes, there was one study that I came across that looked at the experience of the queer MS patient. I think it was in Italy, the study, and queer MS patients were more likely to switch MS centers um, than heterosexuals. So I think that goes to a point about the healthcare experience.
Mhm. And the healthcare experience is so important because if people have a poor experience, as we know, when people are diagnosed with MS, often they may have a symptom that goes away. And so you have a person who's otherwise healthy who, may have a symptom that goes away. And if they have a really bad experience with that first encounter with the medical system, they may not follow up, right? And then they come to us at our
Right,
MS centers
exactly.
5 or 10 years later with a lot of disability because that first interaction was very poor. So that's something we definitely need to be very aware of, and make sure that we are treating everybody with the same, respect, and also honoring their preferences. So when we think about shared decision making, right, there are a lot of talks and we talk about health disparities and shared decision making. There's really this shift to making sure that we include our patients and their care partners in our decision making process when we talk about therapies, et cetera. So, what are some tips that you think would be helpful when approaching, treating MS in certain, in this community, to make sure that we're providing, I won't say culturally competent, but competent care?
Mhm. Yeah, I mean, it could be. I'm a little critical of people. Like, I think, at the very basic level, right? Like, physicians should be aware of, you know, definitions, of
Hmm.
LGBTQ plus people. Like, and I do think it's a little confusing sometimes when there's a lot of
Hmm.
letters and it
Yeah.
seems to be
Unpack it
expanding
for
more and
us.
more.
Teach the people.
Yeah.
Unpack it for us.
Okay. Well, I think the more accepted one is LGBTQ plus days. I think it's the most encompassing one. I mean, there's
Hmm.
LGBTQIA that some people use. There's also just LGBT. But the
Okay.
LGBTQ plus, I mean, basically L lesbian, G gay, B bisexual, T transgender, Q is queer or questioning, right? So we include
Hmm.
questioning people in that term because we consider them part of the community because we want to be welcoming to them. And then queer is
Right.
sort of just an encompassing term for the whole community. And then the plus means
Hmm.
many different things, right? I mean, so plus,
Hmm.
I mean, you think of the IA and LGBTQIA. So I is
Right.
intersex, which is
Hmm.
sort of it's a complicated thing to explain, but it's basically there's like a variation in sex characteristics. So like
Hmm.
people aren't distinctly identified as male or female, so we include them.
Okay.
The A could be asexual, which is lack of
Hmm.
sexual attraction to anyone, and then the
Hmm.
the A could also be ally. So
Hmm.
that's a heterosexual person who considers
Hmm.
himself, a team member of our community. And
Hmm.
we, like I said, we're pretty inclusive. We include
Hmm.
those people in them. Also pansexual. A lot of people are,
Okay.
are, are identifying as pansexual these days. So that's interesting thing about pansexual is that people who are pansexual have an emotional attraction or sexual attraction towards people of like any sex or gender.
Hmm.
And some people are like get confused about bisexual with
Hmm.
pansexual. So
Hmm.
bisexual people is basically attraction to either same or opposite sex, but some bisexuals also consider attraction to transgender
Hmm. Hmm.
part of the definition. But I think what's
Hmm.
important about these terms is that it's not one size fit all. Like some people
Right.
change their identity with it,
Hmm.
and and I agree, it can be confusing sometimes.
Mhm.
So
And what
I think an
about
awareness.
non-binary? I hear a lot about
Yeah.
non-binary. Talk about that.
Yeah. So non-binary. Okay. So I want to take a step back. So gender versus sex, right? So
Mhm.
everybody has a gender. Okay. I have a gender. Everybody has a gender. And we also have a sexual orientation, right?
Mhm.
So, a straight cisgender man, that the gender identity is male and
Mhm.
the sexual orientation is heterosexual, being opposite.
Mhm.
And so we think of, like, there's a sex assigned at birth, and then there is, sort of a gender that doesn't really follow, physical things, right? That's sort of the theory
Mhm.
behind it. So
Gotcha.
transgender people basically are, it's not a sexual, it's not really a sexual orientation, it's more of a gender identity, right?
Mhm.
So transgender people can consider themselves straight, they can consider themselves gay, bisexual, or pansexual, even, for that matter,
Mhm.
right? So as far as the sexual attraction goes, so non-binary basically means that, in the most simplest sense, that they don't identify as either male or female, right? Or they're on a continuum, because really it is a continuum. I mean, just like
Mhm.
sexuality.
Mhm.
And maybe they change their identity based on the situation, or whatever. And so, does that make sense? It's sort of just like a,
Yeah, it
you
does. It
know,
does, absolutely. And I think it's important for people to understand. Now, let's talk a little bit about pronouns. So I know I asked you about tips, but this is good. I
yeah,
think this is
this is
important
good.
for people to understand. So let's talk a little bit about pronouns. So, a while back, I started to notice, I know what it means now, but a while back, I all of a sudden started to notice everybody putting pronouns at the bottom of their Zoom meetings. I realized it because we were doing so many Zooms, and at Zoom, I would see people say she, her, or he, him, So tell us about, how, what the pronouns mean and how it's important to, you know, um, for people to identify by certain pronouns and make sure that we are, talking to people in terms of the pronouns that they identify with.
So I think the pronouns are really part of the gender affirmation process
Mm-hmm.
for trans people, right? So I talked about, when I do a lecture on this topic. I talk about, there's sort of four different ways of people affirming their gender, right? So
Mm-hmm.
I mean, it could be surgical affirmation, which is using surgery to change, an anatomy. It could be medical affirmation, which is basically hormone replacement therapy, but it could be something
Mm-hmm.
as simple as social and legal affirmation, right? So social
Mm-hmm.
affirmation is like changing, like, one's name, pronouns, like their appearance to the world. Legal affirmation
Mm-hmm.
is, actually officially changing, the gender on, like, a driver's license, for example. Obviously, that
Mm-hmm.
depends, state dependent these days. Um, but I think what's important is about this topic is that this is actually a very simple way for, I think, for healthcare professionals to sort of create an open environment to this community, is that,
Mm-hmm.
um, being respectful to, you know one's, way they express themselves to the world, right? So I think, what cisgender people have started doing, is, including myself, is doing like he, him on my LinkedIn profile or my email signature, because that, I think, normalizes this the pronouns for transgender people. And so it creates an open environment for them to feel safe to express themselves in their truly authentic self, right?
Mm-hmm. Absolutely, absolutely. Which is extremely important because when we think about MS and we think about a chronic disease where, you have a lot of contact with your healthcare team, it's very important to be able to be comfortable with people, especially to talk about, issues like sexual dysfunction or other things like that. We need to make sure that, people are in a space where they feel comfortable and where they can talk to us. So back to those tips. Okay, so we kind of skipped all around, but I thought that was really, really important to explain those pronouns and to make sure that people understood, some of the terminology. So talk to me a little bit about kind of what tips you would give, let's say patients who, are entering the healthcare system, with a diagnosis of MS, how to advocate for themselves. I think one of the most important things that people can do is advocate for themselves or their loved ones, their care partners. I have a lot of my patients come in with their spouses, in same sex relationships. And, we talk about all the issues the same way we do with any other couple, So what are some tips that you have for people to really advocate for themselves or to advocate for their loved ones, in the community?
So I think it's tough to answer because like I think with the queer community, back to what I was saying about like mistrust, like what I think is what I do when I go into the doctor. I'm very open about things, but I live up in Illinois, and
Hmm.
it's very nice around here, in the suburbs of Chicago. I mean, so everybody's very open, but like if we're talking about a different state, I can understand the fear. So I mean, I
Like
think
mine. I
those
live in the deep
patients,
South.
yeah,
So
I mean, it's
there's
an
some
issue. It
places that
depends
are
where you
very
live.
open and there's some places that are not.
It's really tough, and I think
Yeah.
yeah, it's tough because like I think so there's two things, right? So one risk of being open is that you might actually encounter a healthcare professional who's actually explicitly biased, right? And so,
Hmm.
but it can be sneaky. I mean, there's something called implicit bias, which is actually a really interesting like sort of topic to talk about. Implicit bias
Hmm.
in the healthcare system. During my master's program, I actually like took an implicit bias like quiz, and it was shocking. And
Mm.
so yeah, it's really interesting stuff. So at the very like sort of and the thing about implicit bias is that the person who is implicitly biased isn't aware of the bias. That's the whole thing.
Hmm.
So
Hmm.
you could encounter that, but I think the one thing that came to my mind was like so like I work in Northwest Indiana, which is south of Chicago. We have a very diverse patient population. We have you know ethnic diversity. We have socioeconomic differences, and we catch a very large population, including like even like country folk, right? Like
Hmm.
people who have farms. Like it's really interesting, my patient population. So
Mm.
I encounter
Farms in
people of different
Indiana. What do they
yeah,
grow?
mostly corn.
Corn. Okay.
Yeah,
Okay.
lots of corn and wheat, and I mean it's lots of cow farms and stuff. But yeah, I mean it's nice. So I actually was nervous about this job initially, about revealing my sort of sexuality. But I've kind of turned into like I'm going to challenge people about it. Like I'm going to be very open about it to people because I also like if they have an issue with me, I don't want them as a patient, right? So
Right.
like let's get that issue in the open before um, something happens, right? So, but I'm not like I don't like walk in a room, oh, hi, I'm Dr. Gonti and I'm gay. Like, what I mean? It's more
Right.
like while we're like getting to know each other, I'm like, oh, yeah, my husband, this and this, of
Right.
course,
Right. Right.
sneakily about that. So that's a good advice. I think a good advice for people,
Hmm.
like patients, to sort of introduce that concept if they're nervous to their doctor. I do
Yeah.
think one, I think for healthcare professionals, on the other hand, I think we have a good opening here. Because, like, so for example, you brought up spouses, right? So
Hmm.
whenever I go into a patient's room for like the first time, or even like a follow up visit, and there's someone I don't recognize, I'm always like, oh, hi, I'm Dr. Conti. Okay, so who are you and who are you? Like, how are you guys related?
Right.
Just to know, like, right? And oftentimes it's like, oh, okay, it's a same sex partner or whatever, and it's like, okay, move on. Now I know.
Exactly.
Instead of being, because I would hate to be like, oh, your friend, or I hate that,
Or your
right?
sister.
I
Yeah, I think that's
yeah,
important.
right,
And yeah, and I've had a
yeah.
patient who had an experience at another place where someone assumed that her wife was her sister. She was like, why would
Oh
they assume
gosh.
that? So I think that's a really great tip is to just always ask, okay, who's with you today and let them identify. And then that kind of gives you a feel for, who their care support team is.
And it's the same thing for like transgendered people. Like I think health
Hmm.
professionals, I think we just need to be. I think the queer community we're actually pretty open about things. Like when asked, like I think I can't speak for everybody. I mean, there's people that do face challenges, and in that sense. But I do think most, at least out queer people, are if you get asked like in a safe way, not like who are you kind of thing, but more like, oh,
Right,
I'm
right.
curious about things. I think we're pretty open about saying it. So for like transgender people, I say like, if you, I mean, one way around it for healthcare professionals, and I think this is the standard of care at this point, is having gender neutral like paperwork and stuff. And Epic,
Mhm.
which is the main EMR in the country, now has stuff in it like it says sex assigned at birth and like current gender, and there's like a even
Yes,
an
uh-huh.
open space
Definitely.
for it. So that's actually an improvement. And then what it'll do is it'll update the chart name, like preferred name,
Mhm.
so I go by Billy, but my legal name's William. So like when I put in preferred name Billy, it shows up as Billy Conti in Epic.
Mhm.
Anyway, the problem is insurance companies still are binary, male female, for billing
Mm,
purposes. So that gets a little
gotcha.
tricky.
Gotcha.
But I think my best advice for healthcare professionals who have transgender patients is really just you want to create an open environment to create discussion, because honestly it's to the benefit of the patient and makes them feel safe enough to reveal things or open up about things they wouldn't have otherwise.
Mhm. And so you touched on something a little bit earlier, and this is kind of right in line with that, but you talked about kind of mistrust because of um past experiences. Are there other ways that healthcare providers can, establish trust with their patients? So certainly asking, who's in the room, who their care support team is, making sure we identify, people correctly by the names they prefer to be called. Are there other things that we as a healthcare community can do to overcome some of the trust barriers from things that have happened to people in the past?
Well, I think from what I said, I think those are easy things to implement. I think
Hmm.
on the sort of the next step is to do, research on this topic. We're looking at the
Hmm.
health disparities that and how does it interact with the MS community. I mean, it's interesting. So really what triggered me to be sort of an advocate for this topic was that a lot of clinical trials, right? So pretty much all the MS clinical trials at this point are excluding patients who are HIV positive, right?
Mm,
Now, HIV positivity is not unique to the LGBTQ plus community, but we
right.
are have higher rates of it than the heterosexual community, and so that really like alarmed me when I was doing these presentations. And it was like, oh, it's contraindicated for HIV positive people. I'm like, well, why? And it was just really confusing to me. And so I started looking, and I'm like, oh my gosh, all the trials are excluding HIV positive patients, including the current like BTKI studies. Like they're all have
Right.
HIV as an exclusion. And the thing is, there's I feel like there's two types of HIV patients, right? So there's a one who's like newly diagnosed, has a high viral load, has all these complications from HIV, and then there's like a patient. This is the majority of patients who have HIV for long-standing HIV, undetectable, normal CD4 count, normal lymphocyte count, and no complication. I mean, so I feel like that group of patients should be being offered best in class therapy for their MS. And I
Mhm.
think more insidiously, these exclusions from the clinical trials have these downstream effects with prescribing habits. Okay,
Absolutely.
so what I mean. Like it's really. I mean, this is a big problem actually. I was giving a lecture once, and the neurologist was asking me, "Oh, what about this? What about that? Oh, what do you do for HIV patients?" I'm like, "Oh, why are you asking?" And she was basically using these low efficacy drugs. She's like, oh, I use these low efficacy drugs for HIV positive patients. I'm like, well, why? Why don't you use the high efficacy drugs? And I'm like, it's just like I feel like we're doing a disservice to this community because we're excluding them from the
Yeah.
trials, and you
Mhm.
know, and it's this downstream
Yeah,
effect.
and it makes me think of a lot of the questions that we need to answer in many communities, right? So, the question always becomes, what do you do with those patients, right? Who have HIV? I've had several, right, who have HIV. They're doing great. Their immune systems apparently work great, and I've worked with their infectious disease doc, and the infectious disease doc is like, give them the best therapy. And I'm like, okay,
Yeah.
so definitely, there is a need to make sure that the populations that are in our research are the populations that we're actually treating in the real world. So when we think about different communities, whether it is the LGBTQ plus community that may have higher rates of HIV, or our minority communities, our, Black and Hispanic communities who may have comorbidities. When we don't have these groups in our clinical research, then we wind up figuring out what happens to them in the real world,
Right.
which is not ideal, right? So it's better to make sure that we are looking at treating people holistically in the way that we do our research, so that when we get out into the real world, that it reflects the people that we're actually going to see in the clinic, because we're going to put the people with diabetes, high blood pressure, and if somebody has HIV and they have MS, we need to treat them. So it's better that we know how to treat them versus figuring it
Precisely.
out and going around to meetings and talking to each other and asking each other, instead of having some of that research. Are there any other data gaps that you see in the research that need to be addressed in this community?
Yeah, I mean, I think, like I said, about sort of the experience of the queer patient, like what are the health outcomes. So, I
Mm-hmm.
think what my belief is that the more intersections there are, the worse the outcome will be.
Mm-hmm.
So like, we need to know, um, sort of what, as an epidemiological study, is this community having worse outcomes with their MS? And it could be
Mm-hmm.
multifactorial. It could be based on, health disparities because of, something called adverse childhood experiences and minority stress. Sure, that could be
Mm-hmm.
causing problems.
Mm-hmm.
Or is it that they're being treated differently?
Right, right, absolutely. And these are extremely important questions that we need answers to. So, in terms of ways for, I always like to, leave our audience with ways to empower themselves. And I think we kind of touched on this a little bit. But what are some tips that you have for people, who are part of this community, who are dealing with MS, who feel like they, may be the only person? Are there resources for them where they can, be directed to? Or what is some advice that you would give, to patients and their care partners to improve their care experience and advocate for themselves?
So I think there's definitely, I've been a little disappointed with like some of the sort of current resources for the MS community that are queer. So I
Mhm.
think other resources, I think there's some associations that provide a lot of services towards LGBTQ plus people. Unfortunately, they're all in the big cities, right? So
Mhm.
Chicago, we think of Howard Brown in the center in Halstead, Boston's Fenway, and so um, it gets a little tricky depending on where you're at. I do
Mhm.
think what we do need, and I would totally help with this if someone wants to. We need like a MS support group, like a virtual meeting, probably for queer people.
Mhm.
So if anybody wants to volunteer, I can be the sponsor.
Yeah.
But yeah, that could be really powerful, actually. And I don't think there's any, to my knowledge, that I've come across that are like that.
Mm.
And
Yeah.
so, because I think one problem with the queer community that I've encountered, just being queer and gay, especially gay men, I think you see this
Mhm.
issue is that there's this. I feel like people get weird when people are sick in the queer community, just
Mm.
like other queer people feel weird about
Mhm.
them. So I think having a, especially something like MS, which is this chronic condition, was that I think it'd be nice to have a support group for MS patients or even neurology patients, that look, there's other people in this community that are experiencing what
Yeah.
you're experiencing. I think it can be very powerful. I think society, the MS Society should take a lead on this, and definitely advocate for the groups. It could be even the pharmaceutical companies, for example. I mean, like put a same-sex couple in one of the pamphlets, right? I mean, just
Mhm.
to show awareness of it, because I think I think most people realize this now, but like, representation does matter, right? I mean, like a
It
little
does.
13-year-old seeing, a leader who looks like them, acts like them, and whatever. I mean, that's very empowering, right? And so I think we have an opportunity to help people with this.
Mhm. Yeah, and I think, as you said, representation is so important. People need to be able to see themselves, and people need to be able to know that not alone, right? One of the biggest concerns with MS is fear for the future, and often many people
Mhm.
become isolated. That is
Yes.
one of the things that I really try to stress to my patients, especially when we talk about people in underserved populations. There are groups emerging, for instance, in the Black community, but there are not very many, right? And our
Mhm.
recent studies suggest that the incidence or the prevalence of MS is similar between Black and white
Mhm.
people. So there's a lot of Black
Yeah.
people, but very few resources. So I always encourage people, if you see a gap that exists, you may be the person to fill that gap. So there definitely sounds like there's a need, for support in that community. And definitely, our society should be helping to kind of reach out. But also, listen, MS is I'm all about patient empowerment, so there are so many online resources, and now since the pandemic, I say everything that we thought we couldn't do electronically, we can definitely do
Oh,
electronically.
yeah.
So I'm sure that they would gain a lot of support for a virtual group of that sort. So as we are kind of coming to the close, I don't see any questions in the chat there. Are there any kind of parting thoughts that you have? I think this has been a really great discussion, and I really hope that people would take something, healthcare providers, I have some docs and nurses that watch, as well as patients, would take something from this to make sure that we're providing, good care, for a potentially vulnerable population.
Yeah, I think the big thing that I'm trying to emphasize to people when I have this conversation is that, look, we are a minority group, and
Hmm.
we're underrepresented, and there's we're not in the clinical trials, we're not, but we're here. I mean, like, there's a lot of people who are queer, and
Hmm.
so I think just sort of awareness of the issues we face is really important. It can affect treatment really and outcomes.
Absolutely. And the other thing I think that is important is to ask, right? So when we think about some of our trials, one of the major issues we had, for instance, with Hispanic Latino populations was that they didn't ask, right? So
Yeah.
you don't know who's in the study because you don't ask. And so I certainly have not seen studies where they've asked about, gender identification or orientation, and so maybe that's something we need to be advocating to, that we explicitly ask in our studies so we can know who's in our
The
studies, and
prevalence.
also encourage people from the community to also participate in clinical trials as well.
No, I agree
Yeah.
completely. Yeah, I think we really need to do a study on this, but it's
Hmm.
tricky because, like, I think it's what is the problem with LGBT people is that there's a portion of people that one might be questioning, for example,
Hmm.
and then another group of people that are, like, may not want to say their sexuality. So it gets tricky sometimes.
Mm.
You
Yeah,
know what I'm saying?
absolutely, absolutely, absolutely. Well, I am very, very hopeful. It sounds like you are definitely in the work and doing the work. And I'm very hopeful that, advocates, amazing advocates like you, will help us to find some of the answers that we need. So thank you so much for coming on Brain Chat today. And thank you all for tuning in. It's Dr. Mitzi, the Nerdy Neurologist. Don't forget to subscribe to our podcast on all podcast platforms. And this episode will air probably in the next week. Thank you all so much, and we'll see you in 2 weeks for the next Brain Chat.